Welcome everyone to Menopause Chicks. This is the Vagina Dialogues. My name is Shirley Weir, and I'm proudly wearing my uterus, fallopian tubes, ovaries, vagina, and butterfly shirt today. And we have a very special guest on the Vagina Dialogues today. Dr. Kelsey Mills is joining us. I am going to introduce Kelsey in just a minute. We're going to be talking about vaginal dryness. We're going to be talking about why this is so important to be at the top of our to-do list. And we're going to be talking about what's new in 2022. So thank you for taking time out of your busy schedule, putting your own name at the top of the to-do list today. And if you're watching this on the replay, thank you for that and for paying it forward. I did a little video yesterday, just challenging all of us when we learn something new here in the Menopause Chicks community. We actually have a responsibility to tell someone younger and to tell someone older. And I think that today is definitely going to be an excellent example of that. Okay, so our guest today is Dr. Kelsey Mills, who is a gynecologist in Victoria, British Columbia. Thank you for joining us, Dr. Mills. I have not had this happen before, but I have the pleasure and opportunity, as you know, of working with amazing health experts. And when I announced who was going to be joining us for this episode of the Vagina Dialogues, my text messages lit up. Oh, she's my gynecologist in Victoria. I love her so much. Oh, I can't wait to hear Dr. Mills. She's fantastic. So we are in for a treat. Your patient panel loves you, Dr. Mills. Okay, what happened there? I just want to make sure everyone's getting in. Okay, so I want to jump right in. This is going to be a conversation. And then we're going to take a few minutes at the end before this hour is up to address any questions that you have. So you do have the opportunity to ask a gynecologist. But I think it's really important to start at maybe the beginning. Maybe you've already taken the Menopause Chicks Masterclass. Maybe you have already watched an edition of the Vagina Dialogues this year, and you know we've talked about all of the options that are on the menu for preventing and treating vaginal dryness. Suffering is not on the menu. You need to know that. And, but I just want to back up for a second. So hormones fluctuate in perimenopause. We know that. We'll talk about which ones in a few minutes. And then we reach menopause. And estrogen goes for a deep decline. And here's what happens, Dr. Mills, in the Menopause Chicks community. And I'll just talk about Mary, for example. Mary is an excellent example of the members that we talk with on a regular basis. Mary is fit, she's happy, she's taking care of herself nutritionally, she maybe noticed some changes to bleeding, but she probably would define her perimenopause experience as sailing through. And then we meet Mary again, about maybe 5 years post-menopause, and she's surprised and frustrated and doesn't know what to do or why she has ended up with vaginal dryness. So what has happened in that situation? I need you to unmute. Oh, can't. It says I'm asking you to unmute.
Perfect.
Okay, good.
There we are. Yes. Thanks, Shirley. And thanks so much for having me on this. I feel like I
wonder why you weren't saying anything.
Yeah. So were any of my patients if they were watching. Yeah, I feel like a gynecology, you make me feel like a gynecology celebrity in BC.
You are.
Very kind. I think that this scenario that you just painted there is very accurate for so many women, in which they kind of make it through the perimenopausal transition. Maybe they've dealt with their hot flashes or the irregular bleeding, or they're coming sort of out of the really difficult sleep challenges. And then maybe heading into their 50s or early 60s, they start to notice vaginal changes. And those are driven by those hormonal declines that you spoke about, where we do see that women's estrogen levels and testosterone or androgen levels also start to decline. And then there are so many symptoms that happen as a sequelae of that. And I can just go ahead and describe this for you if you like. I mean, it is everything from a perception of vaginal dryness, just with sitting or riding their bike or wearing specific clothing or underwear. It can be very painful or uncomfortable penetrative intercourse, in which people feel like they are tearing or they tell me that it feels like sandpaper or splinters. There can be even bleeding that happens.
Yeah.
Women can have bladder changes in which, they start to get infection after infection after infection and have to go for repeated urine tests and end up being on antibiotics many, many times. So there are a lot of different changes in the vulva, vagina, and bladder that can happen.
Yeah. And the lucky ones, I'm going to say lucky, they get to see you. They have good care. They have good care from their doctor, from their gynecologist. Dr. Mills is also a certified practitioner with the American Menopause Society. And so that's amazing. But just before we hopped on the call, you and I were talking about some of the statistics. Mm-hmm. So I will often say to women, don't cross your fingers and hope for the best, mm-hmm. because these changes are likely going to happen. We said probably around 80% of women in postmenopause will mm-hmm. experience vulva and vaginal dryness. Is that correct?
Yeah. And I think, what's amazing about being females in this day and age is that our life expectancy is so long that I say this additional statistic that most women will live at least a third of their life in menopause. But women have such longevity now that many of us hopefully will live half of our life in menopause. And the changes in the vagina and the vulva, those are progressive. It's different than hot flashes that maybe stop after a while. These will continue on.
Yeah, so that's an important myth to break, is that mm-hmm. this isn't something that will get better by ignoring it, crossing your fingers, get better with time. I'm going to ask you why we need to speak with our physician and seek treatment. But first, I want to emphasize, let's say it's Mary's mother. Mary's mother is in her late 70s, early 80s. She does have what you mentioned, discomfort wearing certain clothing, underwear, no longer does the activities, the dancing that she used to do, and has had reoccurring UTIs. Mary and her mother aren't making the connection between bladder or urinary tract infections and vaginal dryness. So I want to set that demographic or target market as well.
Yeah, I think that this is, when you say, what are the reasons to talk about this or treat it or manage it? We don't have to let this get to the point where women are showing up in the emergency department, either in terrible pain, where they're asking for narcotics, for example, to manage their pain from the tissue changes, or where they're ending up in emergency departments with severe bladder infections that can turn into kidney infections. And so this has real impact on women.
It does, to quality of life mm-hmm. and to our caregivers and even, mental health. I mentioned that in the video yesterday. Mm-hmm. So again, I'm just going to invite all of us to make sure that what you learn here today, and take a copy of this video when it lands in your inbox tomorrow and forward it on to your mother, your grandmother, your aunt, your older sisters, your friends, women at work, blah, blah, blah. Okay, let's dive in, Dr. Mills. Sure. So why should we seek treatment for vulva and vaginal dryness?
I think there are sort of two branches in terms of how I think of it. One of it is in terms of symptom management. So you either are the woman who has symptoms, and the ones that we just spoke about, Or additionally, you're a woman who's going to have health consequences from this. So perhaps you are going to have bleeding as a consequence, inability to have pelvic exams to check for cervical health or uterine health because it's too uncomfortable to have an exam. Or somebody who ends up with health problems from the bladder and kidneys from infections. But I think, and you do such a great job of this, Shirley, this is a common complaint, and there are so many options to help women. So I feel the same way you do. There's no excuse not to, help ourselves.
Yeah. And that's what we're trying to do with you lending your time and expertise to us tonight, is close that gap, because it is common. So let's say 80+% of women are experiencing this. The last statistics I heard is that less than 4% of women are currently receiving a viable treatment. So what are the treatment options that are available to us?
So that's a great question. And in my brain, I separate these into sort of conservative management, or things that you may not need a prescription for, and then hormonal management or medical prescriptions. And so in the conservative management category, we have help from vaginal moisturizers or lubricants for penetrative intercourse. Those are a great first thing that you don't need to see a doctor to access. And I know you do a great job in your program talking about, for example, hyaluronic acid derivatives and things like that. And then also engaging pelvic floor physiotherapists if people are having bladder or pain with penetration. So that's the conservative category. And then in the prescription category, and I think it's great if women kind of hear some of these options to arm themselves, so that if they go to a physician and say, I have these symptoms, I heard that these are some of the things that are options, it really doesn't lead the healthcare, the healthcare practitioner, kind of has to be able to respond then. So I divide those. There are some creams that are applied to the vulva and vagina. There are suppositories that can go inside the vagina. And there is a ring that can go inside the vagina that can impact the local hormones. And then there is also a new oral medication. So our choices are sort of creams, suppositories, a ring, or an oral medication.
Right on. And so I want to dial back and do some definitions, because I know that physicians, pharmacists, even myself, sometimes we will say things and not everybody is used to these terms. So we want to make sure that you understand. So I say vulva and vaginal dryness. Sometimes I say dryness/atrophy. So my first question is, what's the difference between dryness and atrophy?
Good question. Atrophy that's sort of a tissue term. So that means when the skin, the tissue, the top layer and the layers of the vagina and the vulva are thinning, they're getting weaker, they get pale, they tear easily, they're losing their stretch and their ability to, expand and contract during penetration, for example. So that's the tissue diagnosis. And then dryness is a symptom that can come as a result of atrophy.
Okay. So it's not, dryness isn't like the check engine light that happens before atrophy.
Now, if you're having dryness, that can mean that the tissues have already started to sort of lose their characteristics. Yeah.
That's a great explanation. Thank you. And then a few years ago, and we mentioned the North American Menopause Society, they coined another term. What is that and what does it mean?
Yeah, so I think where this came from was this working group got together and said, maybe women don't like being referred to as being atrophic, which, can be a challenging word for vibrant women who are healthy. They don't want to be told that they're atrophying. So they came up with this term that is a big, long term. It's called genitourinary syndrome of menopause, or we call it GSM for short. And it refers to all of the symptoms together. So not just dryness, not just pain with intercourse, but everything.
And what would those other things be?
So that's the symptoms of dryness or irritation or pain, the penetrative sex, pain, And then also the bladder symptoms like recurrent infection or feeling like you have to pee all the time, but nothing, not large volumes come out, or having urgency to go to the bathroom. And some of those can be due to menopausal changes also.
Great, thank you. And does it include vulva health? Like
absolutely.
Yeah. Okay.
Absolutely. Yeah. So although the vulva, that refers to the external genitals of a female, and the vagina is really the canal inside, the two together and the bladder all have those same hormone receptors. And so as our hormone levels fall off, the vulva and the vagina and the bladder are all implicated.
Okay. So I'm 55. I'm 6 years post-menopause. I've been on hormone therapy since I was 48. I reached menopause at 49. I tried to do everything possible to prevent vaginal dryness. But now, even though I've been on systemic hormone therapy, meaning I take progesterone orally and estradiol transdermally, it's happening. So let's imagine a scenario where I'm going to my doctor. How do I crack open that conversation? And how do I best decide what option is going to be best for me?
So I think I think that women are really empowered and really smart. And I think that the best plan of attack is you make the appointment and you say, I am a 56-year-old woman. And my symptoms of dryness and pain with intercourse, which is leading to me being less interested in sex or even fearful of sex, and my bladder, these are not acceptable to me. And I would like to try some treatment. And if, your healthcare provider can't come up with any options, then you can say, I happened to listen to this recording, and I was wondering if you would be, happy to give me a trial of one of these options.
Right.
And we have lots of Health Canada approved options that are safe, that women can use for the long term. There is no maximum length of use for local vulvovaginal products. Yeah, this is a whole other topic than systemic hormones. And I think the most important thing for people to hear is that we have very good data to say that using hormones in the vagina does not increase your risk of heart attack, stroke, blood clot, or breast cancer. So we can take that right off the table in terms of risks. So Shirley, I'm happy to name all of the Health Canada approved products right now. So there are 2 creams that are approved. One is Estrogyne, one is Premarin. There are 2 suppositories that are approved, 3, but one hasn't been brought to market. So the 3 that are approved are Vagifem suppositories, Intrarosa, which I think we'll talk a bit more about because it's new, and then Imvexi, which has Health Canada approval but hasn't been brought to market. Right. There is a silastic estrogen ring called the E-ring or S-ring. And then there is an oral pill called ospamifene or Ospina that also treats dryness. So there are so many options. Your healthcare provider should know at least one.
I think that that's so exciting that there are so many options. And it's funny because I was just about to say, when you were talking about the safety and the efficacy and these are localized treatments, and then boom, out of the blue, we've got something new and it's oral.
That's true. That's true. Yeah. And that medication has been around in the US for quite a while. And so it's exciting to have an oral option in Canada for people as well.
Yeah. So when do you think is the best time for women to be making a unique appointment to have this conversation with their healthcare provider?
That is probably at the start of any symptom. And although your community is menopause chicks, Shirley, I will tell you that women who have just had a baby can have severe symptoms of dryness. Women who are on some hormonal medications like birth control pill patch or ring or endometriosis treatments, which drop the hormone levels, can have vaginal dryness. So there are a lot of cancer treatments. There are a lot of women, you don't have to be sort of 60 in spontaneous menopause to have these symptoms or be worried about them, and talk to your doctor about them.
Okay. So there's lots of options on the menu. do we leave it up to our healthcare provider to recommend the one that he or she uses the most, or do we decide maybe what will work best for us and suggest that?
Yeah, I think for a lot of my patients, we take into consideration many different factors. So sometimes when people have more external symptoms, sometimes we'll try a cream or a moisturizer on the outside, for example. If they have internal symptoms, sometimes we'll try a suppository or putting cream or a ring inside. There are situations in which we do combinations of a moisturizer and a local hormone. And cost can also be an issue for women. And, you know, there is advocacy work underway, but we still need to do more to have better payment for these medications.
Yeah, definitely. Okay. And we alluded to the fact that there are some new things on the market. So can you shed some light on that for us, please?
Sure. I mean, I listed Imvexy. That is a ultra low dose vaginal tablet that is estrogen, that it isn't available for us to prescribe yet, but it's likely coming. The oral medication that you mentioned, Shirley, that's a once a day tablet that is not an estrogen, but it is sort of a medication that can act on estrogen receptors.
Okay.
And so that's an option there are some patients who have very difficult time placing medications vaginally with terrible arthritis or, you know, dexterity issues. So that's an option. And then we have this new different class of medication, which is called Intrarosa. And this is a daily suppository. And it works very differently than any of the other options.
Okay.
And basically, it is a pro-hormone or something that is not a hormone yet. It's delivered into the vagina. And then in those cells, it's converted to estrogens and androgens, and then the estrogen and androgen can attach itself to receptors in all of those tissues. So it's a new exciting option because it acts very differently than the other medications we've had previously.
Okay, so it's Intrarosa is the brand name.
Correct. And
but
so
what is the treatment?
The pro-hormone is called prosterone, which is DHEA, which some women will be aware of. Yeah. So we don't have systemic DHEA Health Canada approved, but we do now have vaginal DHEA, which is exciting.
Yeah, it's really exciting. And we could have some members on this call who are joining us from outside of Canada too. So we're kind of announcing that DHEA is available in Canada now vaginally. Correct?
Yeah. And you can ask for this to be prescribed. It is prescribable in all the provinces. So it's exciting because there will be women who, for example, will try one type of treatment and maybe feel like it helps a little bit, but not, that isn't sort of making things to the extent where they hoped it would be. So it's nice to have different classes of medications to have different options.
Right. And so what would be sort of the triage process that you would go through as a prescriber to decide?
So I'm quite practical, Shirley. Patients are not going to take medication if they can't afford it. So the first thing I'm trying to assess is, do people have extended health plans or benefits that cover medications? And then I kind of, think my way up the scale. And then I also try to think about what symptoms might be best managed. And then a lot of women come to the office because their sister or their friend has tried something and it worked well for them. And so they want to try that. I'm happy to give that a go as well.
Interesting. Love it. Love that you consider that. Would age also be a consideration? Age or stage?
Yeah, good question. I think all of these treatments are appropriate for, all women. We don't use ospemifene in lactating or the pregnant population because that's a systemic medication. But I have certainly had all sorts of aged women take all of these classes of medication.
Okay. So if I'm 55 or 75, say it's been 20 or 25 years since menopause, it's still an opportunity for me Love
Absolutely.
that.
Absolutely.
And would the dosage change at that point? Like, would I take it more times a week or?
Not really. We try to prescribe within sort of our safe limits. There is a little bit of wiggle room with some of these medications, but their dosing is very different. I mean, for example, the ring, you put that in once and then 3 months later, take it out and put it in again. The vaginal DHEA, that's a daily suppository. As you know, some of the other suppositories or creams after using it to kind of build the tissue up, then it's twice a week thereafter.
Right.
So,
oh, sorry, I just lost my page for a second. So, no, that's okay. So I'm trying to figure out the advantages to DHEA, and I'm really curious what you think the future is going to look like, because you work in this space. And is this something that is going to take over localized estrogen therapy, work alongside? What do you think is going to happen down the road?
I'm really excited about this medication because it has a different way in which it works, or what we call mechanism of action. So first of all, it's always great to have choice. But what I'm excited about for this particular medication is that in terms of safety, when women use this medication, the hormone is sort of inert when it's placed, and then the cells will take that vaginal DHEA, the cells will turn it into estrogen and androgens. And then once the cells are done with it, what is left over is just an inactive metabolite, meaning if you were to check somebody's blood for serum levels, we're not going to see people having higher levels of estrogen or androgen in their blood after taking this drug. And why that's exciting is because that means that's very, very safe, very local, very targeted dosing.
Yeah.
And also it is giving us the opportunity for the first time to use Health Canada approved male hormone, androgen, in the vulva and vagina. And we know there are receptors there. So it's really exciting to be able to target those tissues with that as well.
Yeah, absolutely. And I love how you describe it, because it reminds me of a phrase that I will sometimes use, which is, we need to give our bodies back what they used to make on their own. And so that progesterone converting like that to, what the vagina was used to for all those years. That's really exciting.
It is exciting. It is.
Go ahead.
I was just going to say, if I can be really sort of a real science geek too at the same time, because, you and I were just talking about how we were at the North American Menopause Conference in the US last month, I guess. Yeah, it was really great.
Really
but
good.
There was really exciting research also with this specific class or type of medication, looking at some future options for women who are breast cancer survivors. And I'm really excited about those possibilities as well.
Yeah, the chat is already filling out, Dr. Mills, with questions, and I did want to address that. I mean, we've talked about safety, we've talked about long-time use, we've talked about window of opportunity to go and discuss it with your physician, which is probably never too early, and it's definitely not too late.
Correct.
To do that. But let's address breast cancer survivors, or those women who have decided, along with their health team, that they're not going to engage in systemic hormone therapy. What are the options for them?
Right. I mean, and this is such a lively, shall I say, topic, because breast cancer is very near and dear to me, both professionally and personally, Shirley. And so I completely understand doctors and patients who want to do everything they can to minimize their patients' chances that their cancers come back or spread further on in their body. The first thing I want to say is that the studies that we have, which are excellent, do not show a relationship between putting low dose estrogen in the vagina and breast cancer risk. So that's really important for women to understand. What's interesting about this new medication, the Intrarosa, the vaginal DHEA, is that because the cells are just using this hormone, converting it in the cell, and then excreting it not any longer as a hormone, there is no possibility for any of that hormone to go elsewhere in the body. So that's really exciting. And this medication does not contain what we call a black box warning against use in women who've had a breast cancer history. So I'm really excited about that. And I'm really excited there is ongoing future research with breast cancer survivors and this class of drug, as well as with ospemifene. So these are going to be two really interesting options because breast cancer survivors do not have enough help in this area.
Absolutely.
So, yeah.
Absolutely. And thanks for bringing up the black box warning too, because that does come up in the Menopause Chicks community quite frequently. And, you can have the best information at webinars like this. You can go to your doctor, you can pick up your prescription from your pharmacist, and then you get home and you still have that anxiety from the warning that's on the box. So I think what you just said is really, it's going to reassure a lot of women.
And if it makes women on this call further reassured, there has been a movement in the medical community and menopause specialists for many years in Canada and the US to have that warning taken off local hormones because it doesn't apply.
Yes. Yeah, that's really good news. Are you keen on diving into a couple questions from our guests?
Sure, happy to.
Thank you so much. Oh, they're always long. Everyone has such a unique story. Okay, so Sylvia asks, are these products for vaginal dryness also viable options for women with previous breast cancer and currently on tamoxifen?
Yeah, so that's Sylvia, that's sort of the biggest controversy in this point is people who are on tamoxifen and aromatase inhibitors. And what I would say is that it usually depends on the overall picture of what your cancer journey has looked like, because there are a lot of women who have had a small amount of breast cancer, they've been through their treatment, they're considered cured, and their oncologists probably would say, you've got a lot of symptoms, go for it. It's very different if you have a scarier type of cancer that, has a really high chance of coming back, or, your doctors are really worried about it. In some of those situations on aromatase inhibitors, they may ask you not to use local products. And I'm going to argue most oncologists haven't yet even heard about Intrarosa, but Intrarosa or ospemifene might be two of the, more palatable options for oncologists.
Yeah. Well, that's going to have to be a webinar for a different day. Is how do we get your oncologist to talk to your gynecologist so that you can get the vaginal treatment that you deserve?
Yes, correct.
Charlene has the same question. So thanks, Charlene, for doing that. Peg has a great question. Is Intrarosa covered by MSP in British Columbia?
Yeah, so I'll just clarify that no medications are covered by MSP in British Columbia. So the question would be, if you have an extended benefit or if you have pharmacare. My understanding is that Intrarosa is not yet covered by pharmacare. They're working on it, I'm sure. It is covered by some extended benefit insurance companies. But that you would have to check with your own coverage. I think it's about $40 a month, which is on par with Vagifem suppositories.
Great, thanks. I was going to ask you, and I didn't want to put you on the spot for how much it actually costs to take care of our vagina every month, but it's worth it.
I would argue it's worth it.
It's worth it. Okay, Barbara is 69 years old and wants to know, is 69 too late to start progesterone pills? So that's a bit of a different topic. How long after you start can you expect changes in vaginal atrophy? Okay, so a little convoluted, Barbara, because why don't I let the expert explain systemic hormone therapy versus vaginal hormone therapy?
Sure. I mean, when we're talking about, maybe I'll answer the question in a bit of a different way. in terms of if you're using hormone in the vagina or vulva, usually it can be several weeks until people start to see changes. With intrarosa, the DHEA, the data from the study said women had effect even at the 14-day point. So pretty soon or quick onset of action. In terms of progesterone, that is not something that we're really going to be using for vaginal symptoms. That would be off-label use if people were doing that. Have people studied this? They have actually studied putting progesterone, micronized progesterone in the vagina.
Right.
It probably helps a little bit, but that's not a approved reason to do that.
Got it.
Most women are taking progesterone systemically by mouth, sometimes vaginally, to complement estrogen as part of systemic hormone therapy, or sometimes on its own to try to deal with usually nighttime symptoms.
Right. Okay. So are physicians prescribing DHEA in Canada right now? Okay.
Yeah.
Is the oral medication, I'm not sure if you know, I have experience with that yet, but is the oral medication, will that also help other symptoms, or does it strictly target vaginal dryness?
It strictly targets the lower tract, the vagina and the vulva. And what's interesting is that one of the side effects might actually be some hot flashes from using that medication. So ospemifene, or Osphena as the trade name, that is really strictly for vulvar and vaginal symptoms.
Yeah. And as Dr. Mills mentioned too, like everyone is unique. Everyone is at a different age and stage. Even sometimes we will have conversations about everyone has a different body size and shape. So all of those things can go into your shared decision-making with your practitioner.
And Shirley, I just wanted to reiterate something that you said, which is even if you're on systemic hormones for hot flashes, sleep, etc., because we give such safe, low dose hormone therapy in this current era, a lot of my patients will still benefit from vaginal hormones, because we're giving people such safe, low dose options that they could still have a bit of a boost if they're and use something local.
That's a really good point to emphasize, because going back, if you missed the beginning of the call, if you remember the beginning of the call, we're talking about why this is so important. So doing both might be the answer to your why, because you obviously want to avoid vaginal dryness and atrophy, but you also want to take care of the urethra and prioritize your pelvic and bladder health and so on. So yeah, I love that. Brenda's asking, can you list a few moisturizers you would recommend?
I think something that my menopause mentor, who taught me everything I knew, said, she said, go to a drugstore and look at all the options, and there are so many options out there. Read the ingredients. Absolutely. There's actually a great guideline on this from the North American Menopause Society. But some women, find everything from using a natural oil or natural cooking oil that helps them, all the way to, products that are available at a drugstore, health food store. What I usually caution women is that anything that is flavored or tingly or, generates heat or cool is not a great option for the vulva. Because that can be irritating. Or scented. A lot of people have allergies or will get like a chemical or contact dermatitis. Yeah.
Good. Okay. I'm 59 and have been using the S-string for 6 months. It has helped with some of my symptoms, but I'm still experiencing painful intercourse. Both the pelvic physiotherapist and gynecologist say the skin looks good. Could it be the wrong treatment or another reason for the pain?
I think both, and maybe not the wrong treatment. I think it's great to try things. As Shirley said, we are all individuals, and this is never going to be a one size fits everybody scenario. I have a lot of women who swear by one product and the other next patient comes in and swears by the next product. So I would encourage you to try different things. Also, I have a lot of women who sometimes are using a inserted hormone who also will use a little bit of a cream on the outside or a moisturizer on the outside. And then I'm also a huge fan of vaginal dilator therapy, because that can be one of the ways in which we can overcome penetrative pain in menopause.
Yeah. And so you can learn about dilator therapy with your gynecologist and or your pelvic floor physiotherapist. They're well trained in that as well.
Absolutely.
Amazing. Okay. Isabel says, this is wonderful. Is the new daily suppository less expensive than Vagifem?
They're the same.
Answer that again.
Yeah.
Same price. That's good news. Okay. Brenda says she has a challenge, I think, with the mode of delivery. Should all the estrogen be absorbed? I often have cream fall out in the morning when going to the bathroom.
And I think that what's interesting about that particular medication is that you could be using quite a bit. Their monograph on that drug used to be quite a bit of cream, 2 to 4 grams, and then they down dosed it. So women can get results with that medication even with 0.5 grams. So you could try using a little bit. You could try, I tell women always to put it in at night. You're only using it twice a week if you're in the maintenance phase. But if a little bit of cream comes out, that can be some benefit to the vulva. And we don't have to worry about it. I always say if someone gets on a male partner, he will not turn into a woman. It is going to be okay.
I know it. I think it's important for us to, we have a lot of information, a lot of health information coming at us. And so I understand it can be confusing and overwhelming for some of us, but when you're having a conversation about hormone therapy, jot this down. Am I using the right hormone or hormones for my age and stage? Am I using the right dose? And is this the best mode of delivery for me? And it might not be. And you might, as Dr. Mills said, just want to switch it up and try something else for a while and see if you like it better.
Absolutely. And I think it's great. I do this all the time. I say to people, so what we've tried is not perfect. This is not doing the trick. So let's try something different.
Amazing. I am 62 and using Vagifem 3 times a week. Can Vagifem be used more than 3 times a week if needed?
That's a great question. I will get technical again for you here, Shirley, that medication is a 10 microgram dose. Okay. That's what's in one of those little suppositories. Right. They showed safety data on that medication for a 25 microgram dose. So I have a lot of patients who use it more frequently than twice a week. It's technically off-label, so that the government isn't approving us to use Vagifem more than twice a week once we're in the maintenance phase, but it's a very low dose medication. But if you feel like you're using it 3 times a week or 4 times a week and you're really not getting the symptom control that you were hoping for, you might be a good person to go back to your healthcare provider and say, maybe I want to try something else. There are new things out there. Maybe I'd like to try something else.
Right. Okay. How long? Okay. I think we answered this one, but Mary Lynn wants to know, how long is it safe to use estring?
This is truthful. I have many 97-year-olds in my practice who have been on vaginal estrogens for their entire menopausal careers. And specifically the estring, we use that a lot in that population when it's difficult to, place medications. So you can use that until the end of your days.
Okay. A, I love that. And B, can you just say menopause careers again?
I just did. That's right.
I love it. I love it. Kathleen wants to know, do any of these treatments help with clitoral atrophy?
That's a great question. And something that can be very frustrating to a lot of women. The first thing I want to say is that the nerve sensation, clitoral sensation, tissue sensation, we know that goes down with age and with menopausal status. So if you're experiencing that, if you think that's what's happening to you, you could absolutely be correct. And I think that's an important thing to bring up with a healthcare practitioner. Sometimes for some of my patients, we use some topical hormones on the outside can be helpful. But using some other things like, for example, incorporating vibrators into a self or partnered sexual practice can help with clitoral sensitivity or improving orgasm, because orgasmic strength can also decrease as we age too.
Amazing. This next member, I was just diagnosed with I don't even know if I can say this properly.
Lichen sclerosis.
Yeah, thanks.
You got it.
Do you have any information on this?
So first of all, that's a very common vulvar skin condition, and good for your provider for A, listening to you, B, doing a vulvar exam, and then giving you, a diagnosis. This is an important diagnosis not to miss, because there is a very small linkage with this diagnosis and cancer of the vulva. So we really want to be on top of it and having those exams done of the vulva. And then the other reason it's important is because it can cause destruction of the vulva. So women can see that the labia get reabsorbed, the skin around the clitoris can fuse over, there can be lots of narrowing. So it's really important to follow a treatment course with your provider. And usually that has to do with topical steroids and topical hormones. And
wow.
Yeah, but it is very common. You are not alone.
Is there an association, or I don't mean to put you on the spot, but or a website, because we need to beef up our information on that?
Yeah, I would recommend the ISSVVD, which is the International Society for the Study of Vulvovaginal Diseases. They have good information on that.
Thank you. We will do that.
It's common. So let's talk about that.
Yeah, for sure. Debbie says, I was feeling very comfortable with localized estrogen for 17 months. Then I started getting GSM symptoms again. Why do women get these flares? Or reoccurring flares, I think. That makes me think, is there a concomitant vulvar skin condition? Because things like lichen sclerosis, which are very common, they do come in flares, and then they settle, and then they flare, and then they settle. And so I'd encourage you to go back to your nurse practitioner or physician and say, I'm worried that something else might be going on. Can you do an exam and just make sure that we're all comfortable with this diagnosis? Great script tip there too. Are there any side effects from, was she saying estrogen, but are there any side effects that would be commonly associated with vaginal hormone products? The funny one is that the biggest side effect is vaginal discharge, right? Because what happens is women who had cyclical discharge their whole reproductive careers with the menstrual cycle, then that stops when your ovaries are no longer ovulating. And then you put hormones back in, and then there is lubrication and moisture and discharge present. So that's the number one thing in studies that people reported. Which is not a bad thing if you're moving away from the dryness end of the scale towards the less dry. Can you use vaginal estrogen as well as hormone therapy? Absolutely. Is Interosa available in the US? What's awesome about this medication is that it's actually a Canadian medication. I don't practice medicine in the United States, so I can't recall. Do you know, Shirley, if it's available there? I think it is when I first started looking into this 2 or 3 years ago, but we'll verify that for you. And we're going to run out of time shortly here. And I know that there's quite a few questions. When you put up Ask a Gynecologist, you get a lot of questions. It's my pleasure. We will, if you don't get your question answered, I am saving the chat and come back to the Menopause Chicks community tomorrow, and we will continue this conversation. Cindy says, when I hear DHEA, I immediately think of hair loss. Given its localized action, it seems unlikely or impossible, but some women are reporting it. What are your thoughts? Yeah, I haven't been made aware of anybody who's taking vaginal DHEA who's having a symptom like hair loss. That is a very interesting question, but because of its mechanism, I don't actually believe that would be a part of the side effect profile of this drug. Makes sense.
Mhm.
Hi, joining from Australia. Been prescribed Vagifem inserts for some Euro symptoms, but very anxious about using it and not comfortable with the applicator. Can you insert the caplet without the applicator?
You absolutely can. You absolutely can. And there are some women, you know, when they first start out with a cream or a suppository applicator, they get even a bit of bleeding because things are
Yeah.
so dry. And so I tell women, you can put even a little bit of lubricant on your fingers, stick the tab to that and push it in. You know, trying not to envelope the entire tablet in lubricant. You want it to contact the surfaces as it dissolves, but it could be uncomfortable to insert a finger at the beginning, but you absolutely can.
Amazing.
Mhm.
Well, thank you for taking all these questions. Again, if you
Yeah.
have more, please pop them into the chat and I will be saving the chat and address them tomorrow. And I want to use our last couple of minutes to ask you, I used the phrase script tips just a second ago. 52% of women in this age demographic are currently leaving their health appointments feeling dismissed and disappointed.
Mhm.
Part of that is perhaps physician awareness and education, but a lot of it rests on our shoulders as well. We need to show up informed, and we need to kind of show up with comfortable language and conversation tools. So if you could coach us, and we didn't prepare for this, so I'm totally putting Dr. Mills on the spot, but if you could coach all of us into how to show up at our next health appointment and have an informed conversation about vaginal health, how would that sound?
I think, you know, well done, Shirley. That's super important to make advocates out of your community. And I think there are a couple of points I would make. Of course, you're going to hear it, especially in British Columbia, that doctors, you know, are few and far between and are super pressed for time. So I would encourage you to come in organized and talking about a dedicated topic. So it's very difficult if you're there to renew your blood pressure pills and you think your anxiety is a little off, and you also have vaginal dryness, and also you're not sure about your blood sugars. So make a dedicated appointment and say, I'm here today. I'm really worried about my vaginal dryness. This is important to me. Do you have options that you would feel comfortable prescribing to me? And if not, here are some of the things I've heard about. Are any of these some of the things that you and I could talk about? And coming in armed, I mean, with information, with maybe even a medication name, you could say, it happens to me. Patients say, my friend told me she tried this, it really helped. It's like, great, let's try that, you know? So I think that's really important. And I think just making sure that your provider is aware, you know, this is having an impact on my quality of life. What can we do about this?
That's amazing. Okay, here's a tougher one.
Sure.
How do we crack open this conversation with our mothers and our grandmothers?
That's a great question, especially because oftentimes women may have a similar experience to their mothers. I think, you know, you sit down and you say, listen, in this day and age, I hope you would be really proud of me. I am interested and informed about what's going on with my body. These are some of the things I've heard of that can be really
We just ran out of bandwidth there. Hopefully we get Dr. Mills back. Well, I'm so glad this didn't happen earlier. Okay, looks like she's frozen, but I am going to consolidate Dr. Mills' answers to how to have this conversation with your healthcare provider and with all of the women that you love. And I'll put that in the Menopause Chicks community tomorrow. I want to thank you for taking time. Oh, there she is. She's back. And now I just need to get you to unmute.
Sorry, I don't know what happened there.
Okay, you're back. Yeah.
I don't know how much you heard of that, but it would just be encouraging, you know, open conversation and even going with your mother or your friend
Yes.
as a support person to the doctor to say, these are important, this is important. We really, we don't want to leave here until we have some options to deal with this.
I just love your persona and how you have dedicated your career to this and those answers. So I'm going to just add one more. I'm sorry, but I have to. I have a 19-year-old daughter.
Yeah.
So we have to talk about this with our daughters as well. You alluded to postpartum and the birth control pill. I think it's really essential that younger women hear us talk about vaginal dryness, so that we're removing some of the stigma attached to it and removing some of the myths.
And I think that maybe pregnancy is a great time to have that conversation, and just say,
talk to me about it when I was pregnant.
Yeah. And it can be awful. It can be awful. And, to be that mom who says to her daughter, by the way, this is something that our family has experienced before. If this is an issue for you, there are things you can try.
Amazing. Amazing. Well, thank you so much. We're nearing the end of the hour. I could chat with you all day.
Me
but
too.
your knowledge and your script tips are going to be tools and resources that continue to live on in the Menopause Chicks community. And hopefully you'll come back again.
My pleasure. I know
We'll have
one or two things about systemic hormones too, just so you know.
Yeah, exactly. Thank you so much. I know you have a very busy schedule and really appreciate you donating this time and expertise to Menopause Chicks.
Yeah, it's my pleasure, Shirley. Thank you. And thank you so much for the work that you do in this space.
Thank you. Thanks, everybody. We'll send you the replay tomorrow in your email. Good night.
Good night.